So there has been some new studies coming out regarding spinal decompression.
Non-surgical
spinal decompression. And this was the first high-quality randomized controlled trial that compared decompression tables that have different body positions.
Mm-hmm.
So it tested different tables using spinal non-surgical decompression or traction therapy in laying on their back, laying face down. And I think some of them even had patients laying inside lying.
Mm-hmm.
And what it found was it didn't matter what position the spinal decompression table used, all of them showed improvements in pain and function and outcomes for those patients.
Yep.
But I think the study that showed the best position, that got the best outcomes with non-surgical spinal decompression, was the supine position, which is the position of the patients laying on their back. They tend to get, those tables got better outcomes for patients in this randomized controlled trial than the tables that had patients laying prone, which was face down, or on their side. So that was an interesting study that did come out. That was actually 2026 study. So we'll reference that that study down, and then people can take a look at that.
And so the whole purpose of this study was it's a piece of the puzzle.
Yeah.
But it's an important piece of the puzzle because there's so many different approaches with non-surgical spinal decompression and different positionings and different tables. And so they wanted to see which one had the biggest impact and which one was more effective.
Yeah.
And so there wasn't, by the end of the treatment protocol, there was no significant difference between all positions.
Yeah.
One thing that they did find was the patients who were laying on their back found faster improvements in the beginning, and then everything kind of balanced out towards the end.
Yeah, so all three positions improved pain and disability in that research study. There wasn't, like you said, the laying on their back eventually all mitigated to a similar result towards the end. So the key takeaway was that spinal decompression, whichever position it's in, did have improvements for a lot of the patients, a lot of the test study patients in pain and disability. There was improvements definitely. So we definitely need more research on spinal decompression.
Yeah.
There's not enough. There is some. There's not enough.
Yeah. You can always have more.
Yeah.
Right? What ends up happening is one research study exposes another question that needs to be answered. And so it never ends.
Yeah. Research is continuous.
Forever.
Yeah.
But what it does do is it shows if there was the question of which one should I be doing and which one's going to give me the best outcomes. So they're all going to give you a positive outcome.
Yeah.
The only small variable was laying on your back obviously was more comfortable for most patients, which means they were able to relax a lot more, and the impact was a lot quicker in the beginning.
Yeah.
But overall, they all had a positive outcome.
Yeah. I think laying on the back is much more comfortable for females than laying prone, which is face down.
Yep.
Just anatomy.
Yeah.
Just more comfortable to be on our backs than to be facing down or even side lying. Side lying can be very tender, especially for a lot of women that sometimes have back issues, spine issues or disc issues, but also have hip issues. A lot of bursitis, a lot of inflammation. So laying on the back in that study showed a little bit better outcomes in the beginning, but all decompression that they tested actually did show good outcomes, which was excellent. Beautiful. So it all needs to be adjusted based on patients. Even for older patients, laying on their back was just a lot easier than being prone or side lying too in that study. So, but that was a small study. They need to do more research.
Yeah.
Yeah, because the sample size was pretty small for that. So the key takeaway is more studies need to be done on spinal decompression.
Definitely.
Yeah, and we're definitely looking forward to more studies coming out.
Yeah.
And we wish we had more time. We would have run our own randomized controlled trials, but there's no such time right now. More research needed. All right, now the next section?
We're going to be doing a case discussion.
Yeah, or patient journey.
Patient journey.
Yeah.
So we're going to try and keep it general, but I'm going to let you run with this one.
Yeah. So a little bit of the patterns that I see with my patients and what's the most common things that I see. So generally, my patients that I see for back pain, have sciatica, are females between the age of 30 to 45. That's generally the most common age that I do see. A lot of them have young families and a lot of them are caring for elderly parents as well. And they generally present with chronic back pain or neck pain, pins and needles and numbness down the leg or down the arms, chronic stiffness that they haven't been able to alleviate with other therapies, and they have tried. They have tried lots of different things. And then the most common thing that they do say to me is this going to be my life forever? Because by then that pain's become chronic.
Yeah.
They've had it for at least 6 to 12 months. It's starting to impacting on their life. It's starting to impact on their sleep. It's starting to impact on their function. Whether they're homemakers or whether they're working, and a lot of my patients are working either in teaching or in nursing or in administration or in healthcare, and they are on their feet for long periods of time or sitting at a desk for long periods of time.
So they've got a full-time job.
Yeah.
Then they get home and they've got a full-time job there.
Oh, God, yes.
And then there's additional work caring for others.
Yeah.
So there's a lot of obligation on their shoulders.
Yeah. Women, especially from, ethnic cultures, are expected just to do it all and balance and be grateful.
And function.
Not allowed to complain.
Be a mum, be a wife.
Oh, the pressure is so hard on women, honestly. We definitely do too much. So they come to see me and they've done a lot of different things and they're really frustrated with the fact that they can't sleep. Some of them over 35 or 40 are also navigating around the perimenopause era, which throws a whole nother spanner in the works.
Another challenge.
Everything aches, everything hurts, sleep is broken. Sometimes they have hot flushes, sometimes they don't.
Yep.
Not all women get hot flushes, but a lot of them do experience like low mood, irritability, brain fog. So they come in with a lot of different things. Complex pain, long-term chronic pain, constantly multitasking, caring for others, and navigating the hormonal challenges. Wow. Yeah, it is crazy. So the first thing we need to do is understand their lifestyle and then assess to see what's driving the symptoms. And there are so many questions. Like that first appointment.
Like a forensic investigator.
It's like a forensic investigation, I swear. So many questions. But if we don't understand the context of why they are there, what is driving their symptoms, we cannot formulate a plan to get them out of it. Because you can't just throw random treatments on a person and expect something to stick. There needs to be a plan. And this is what I find is really important for women. Women we don't want to use our brain. We are tired of making decisions. We are tired of deciding everything for everyone and not understanding what we need for ourselves. Yeah. So when they come in and we do the assessment and we come up with we find the diagnosis, then we spend a lot of time explaining what's driving their symptoms. And sometimes what's driving their symptoms is different to what they thought was driving their symptoms.
Such as? Such
as, for example, their back scan might have shown a disc bulge, for example. But the driver of their pain was not the disc bulge after it's been assessed, we've assessed. It might have been their hip, trochanteric bursitis. It might be their sacroiliac joint. It might even be their pelvic floor.
Wow.
So once we get to the root of what the symptoms are being driven from, then we can educate them, and then we can come up with a plan, and then we help them navigate out of that.
Can I just add something? So when the patient presents with pain, what their body is telling them is, I am not coping.
Yeah.
So what the patient or the person in pain needs to understand is your body is communicating with you constantly.
Yeah.
What are you doing to your body to get it to that state? There would have been signs and signals where the body is aching and sore. It would have been manageable in the early stages.
Yeah.
But the obligations tend to override what their body needs.
Yeah.
So they end up in that state where they can't cope anymore.
Yeah.
And now their obligations are being impacted.
Yeah.
And this is when they tend to show up for care.
Yeah.
And so, okay, the driver is their back and their hip and their soft tissue and their instability.
Yeah.
But really the driver is their inability to identify or interpret what their body is telling them.
Yeah.
To be able to act soon enough and to give their body the time and space it needs to heal and recover and repair early on.
Yeah.
And so what that really requires is more than manual therapy and rehab, is being able to identify what their body's saying to them.
Yeah.
And allowing themselves to have that time and space to heal,
Yeah,
recover,
and giving
repair.
themselves permission that it's okay to look after yourself.
So no matter how good your diagnosis is and
Yeah.
how good your treatment is, if you cannot identify that there is a pattern of behavior with this client, with this patient, that has led them to this position.
Yeah.
Make them aware of it.
And that's really confronting when we
Really
have to address
confronting for
that
them.
to them. Yeah.
And allowing them to give themselves the permission to heal, recover, repair.
And give themselves the space.
Time,
Because how much just women are taught to just get on with it.
obligation.
Or they're just gaslit and told that there's nothing really wrong.
Don't go there.
Oh, that's a whole nother issue. But yeah, so that's a very common patient presentation that I see. And the journey for that patient is not just the physical therapy that we need to do or the rehabilitation. It's education on the drivers of the pain and their patterns and what needs to change, because a lot of the times things need to change.
I find the most powerful tool in that treatment room is education.
Yeah.
And in some cases, I cannot say it. I need to be able to guide the patient through questions to help them connect the dots.
Yeah. I think you have a lot of that. You need to guide a lot of your male patients. Males do not like to share important information very well. What is it about males? My God. Females will just come in and tell me, Houda, it's like this. Brilliant. The more information they give me, the better it is for me to be able to understand what they're going through it. Males, what do they do? Like, they don't really tell you what's going on. They expect you to figure it out. And you're constantly questioning, trying to extract the information that you need to be able to give that patient the best outcome.
So yesterday, patient comes in, history of lumbar disc issues, treated, managed really well, had sciatica, shooting down his leg, couldn't function. Treated with non-surgical spinal decompression, manual therapy. He got so good, he just disappeared at the end. So really what needs to happen is really at that point is where we start to dive deep into the rehab.
The rehab.
So it's more than just the exercises that improve mobility. This is where we have to start to strengthen and reinforce what we've done.
Yeah.
He disappeared.
Okay.
Which is what they do. As soon as they feel good enough to get back to the job that they're doing, they're gone.
Yeah.
this is the worst thing they could do, because what ends up happening is they end up coming back a few months later, 6 to 9 months later, up to 12 months, in the same type of position, sometimes worse, sometimes not as bad. But this one he wasn't as bad as when we had first seen him. There was no sciatica, it was just hip pain. There was one thing that he didn't want to tell me, because he didn't want me to say a particular thing or prescribe a particular thing.
Or stop him from doing something that he wanted to keep doing.
That's the truth. So what's happening at the moment is this game called paddle is going off.
Yeah.
Right? Fun game, team sport.
Yeah.
And guys are just loving it.
Yeah.
Right? So this guy from sciatica, unable to walk, function, sit, sleep, drive, has been participating in 4 days a week of paddle, 90 minutes to 2 hours each session. And he had aggravated his hip. And so with the questioning, he thinks it's his back. I'm telling him it's not your back, it's your hip. And just explaining to him where the pain generators are, and that it's not his back, but it could be his back. We just can't tell at the moment. There's so much noise.
Yes.
So when I say noise, there's a lot of pain noise.
Yeah.
So there's multiple pain generators. And the way I had to explain it to him was to imagine there was a Wi-Fi signal in my room, right? And it pushed out this signal to this area. Then next door, they have their own antenna and their own signal pushing it into their room, but there's an overlap into my room. And then there's another Wi-Fi signal in the next room, which supplies that room, but then pushes a signal into our room. And that overlap of signal is where he's feeling that pain.
Yeah.
But really, the pain generator is coming from those antennas. You might feel it there, but it's coming from these
different
sources.
areas, yeah.
And one signal is going to be stronger than the other. And so his question was, so how do we treat it? I'm like, that's my job. I'm going to treat whatever is the strongest today. And so we address the strongest signal today. And we'll try to calm that down. That signal will start to drop off. Then what's going to happen is the next strongest signal is going to be more prominent. And it's going to be somewhere else. Then we'll address that.
Yeah.
And then once that's down, then there's going to be one more signal, and then we're going to address that. And this takes time. And this is our job clinically, is to determine what the main pain generator is that day. Yesterday it could have been different. Tomorrow it'll be different again.
Yeah.
But today, this is what we're doing.
Yeah.
And this is how we're going to treat it, and this is what I want you to do when you get home. But towards the end, I had to explain to him that the real cause of his problem is not his back, and it's not his hip. It's his mindset and the way he treats his body. So this guy works with cars, he's a mechanic. And the analogy I had to give him was, a car comes in with mechanical issues, engine issues, you repair the issue. The owner takes the car back and then starts ripping burnouts out in front of your workshop, and then thrashes his car and then blows the engine again. So was the issue the engine that you repaired, or was it the driver? You repair it again. Then he takes it to the racetrack.
Yeah.
And he blows something else.
Thrashes it.
Then he comes back, and then you got new repairs. Is the issue the car or the driver? By the third example, he realized that it was the driver.
That he was the problem. Men don't like that.
No, he didn't like that, but that's okay.
They don't like to admit that they're the problem.
Yeah. And this is very, very common. It's extremely common, because they come to the clinician, whether it's a physio or chiro or an osteo or whoever it is, their GP, with a problem, thinking that it's like a workshop. You go in, change your brakes, drop the oil, do some repairs. It's good as new. Now we can thrash it again and do what we were doing before. You can't do that. Your body is saying, I can't cope with what you're doing. This is excessive. and it's breaking down. That's the part they can't quite accept, I think.
Yeah.
I think it's because most of them are middle-aged, so 40s and over, but their behavior is that of a 20-year-old thinking that they're 20 and within 3 days everything is going to be fine.
How do your male patients go in terms of rehab compliance? I know with my patients, which are predominantly women, they're actually okay when I refer them off for rehab or Pilates or hydro or whatever it is that I make that recommendation based on their case. They're pretty compliant because they don't want to go back to that dark place ever again. They don't want to be in that chronic pain cycle and broken sleep. You know, we've got them through that. Now we're building the strength, the tolerance and the load resistance. So they're good. But what are your male patients like?
Okay, so there's a few different categories that come up, right? So you've got your tradie, for example, who has no time for rehab. And so his type of rehab, I can't give him more than 2 or 3 exercises. Most of the time it's 1, because 1 for 2 minutes a day, I can get him to do it every day. As soon as I add a second or a third, I've lost him. And I prefer to get that daily 2 minutes of mobility work or strengthening, which is going to compound and give him an impact. It's going to impact his condition greater than giving him 3 or 5 where he does it once a week and never again. And so there's that type of person who's time poor, and there is so much work that he needs to do and everything's on his shoulders that he doesn't have time for the rehab. So with them, it's behavior modification, really simple mobility or strengthening exercises, and not many of them. And I have to try to give them exercises. So I need to understand their environment and what it looks like. And then I can give them exercises that they can integrate into their environment, where they don't have to step away from their environment and go to the gym or sit in a room and do it, where he could be on site and he could be doing a mobility exercise. He could be in his car. He could be sitting at his desk. He could be, you know. The next one is the person who is an avid fitness freak and gym trainer, and he's there 4 or 5 times a week, but presenting with musculoskeletal pain conditions. The biggest issue there is this is the training routine they've been doing for 20 years, and they don't realize that their body has aged and their rehab needs to change to adapt to their body now at this point in time. And so the loading that they were doing in the gym when they're 20s and their 30s, now they're 40s getting into their 50s, the joints and the ligaments and the tissues can't take that load anymore.
That load, yeah.
Or it can't recover quick enough.
Yeah.
So those 4 days back to back, 5 days back to back with the heavy loads, not much deload sessions, is really what's putting them in that position. And so having them understand that their body's not coping with that and they need to modify their training is hard to accept, purely because they don't know anything else. This is where they need guidance on other options of rehab and strengthening. But then the catch there is it doesn't give them the rush. And so it's a really tricky position to be in.
Yeah.
And so it's difficult.
Yeah.
It's much more than manual therapy.
Yeah.
We are educating, we are coaching, we are guiding patients with the manual therapy as well. And I find that is more challenging than the manual therapy part.
Yeah.
The manual therapy part is the easy part.
But convincing people to do what they need to do to get them out of that situation.
Not convincing. Allowing them to see that their body has aged. That's the first thing they have to accept.
You need to convince them that their body has aged, because you know what, most of us are just in denial.
Yeah, yeah.
We don't want to know that we have to change our exercise routines because our body is no longer what it used to be.
Yeah, our body's no longer coping.
Yeah.
Yeah. And
That's true for females too.
Yeah.
Try getting a female who's got chronic back pain to stop her HIIT classes.
A
She loves
female
it. It gives
who's
her the
had
rush.
3, 4 kids, has a little bit off topic. Pregnancy is traumatic to your body. It causes structural damage.
Yeah.
Having 3, 4 kids,
Ligament laxity.
and ligament laxity, and having those structural injuries from the pregnancies and over those years,
Muscle separations.
yeah, yet they still want to do,
Like the intense.
I'm not going to say, still wanting to do high impact CrossFit type training and competitions, which their body is saying, I can't cope with.
Can't do it anymore.
Yeah.
Because it's not the same body that it
No.
was before it had the kids.
No. And the key takeaway from this is, as we age, our exercise and our activity needs to adapt to our body at that point in time, taking in mind the injuries that we have, the underlying pathologies, and any other health conditions that might be associated at that point in time. The exercise needs to accommodate for that.
Yeah. But the most important thing is there needs to be exercise.
There needs to be exercise.
There is no negotiation.
But there are so many different types of exercise that we could do, which our body can adapt to, and you can still enjoy. It just doesn't look like what it used to look like. So we have to let go of those 20-year gym routines, which are no longer serving us.
Yeah, which I have to go through a lot with some of my patients too. That, especially if they've got, had previous pregnancies or having back pain or neck pain or sciatica pain, I have to change. Things have to change.
Yeah.
Because sometimes that drives the pain to keep repeating, doing things that they love. So it's not about stopping them from exercising. It's just about tweaking it for them.
And so the core of it every single time is you have to listen to your body.
Yeah.
And pain is communication.
Yeah.
Pain is information. It doesn't have to be sharp stabbing pain. It could be tightness, stiffness,
Spasms, cramps.
Your body's sending you a signal saying something's not right with this movement, or something's not right at this point in time, and I don't like it, right? It doesn't mean stop it. Maybe reduce the intensity, reduce the load to a point where your body can cope, and then maybe increase back up again, and then, it's going to be up and down.
Yeah.
There's no one flat, consistent routine that you have to stick with.
Yeah.
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 And your recovery is dependent on your sleep, on your nutrition.
Oh God, sleep.
Yeah, sleep is recovery. No sleep, no recovery.
Oh, the mums that have broken sleep, honestly, their pain is always amplified. They feel everything like a lot stronger because sleep helps your body recover and reset.
Sleep is healing.
Yeah, definitely.
If you want to fix anything when you're in pain, you have to fix your sleep.
Yeah.
And it might be pain medication to help you sleep at that point in time, but fixing your sleep
is so important.
Yeah.
Yeah. So with those patients, my female patients, my common patterns that I see, their treatment can include different things. Sometimes just manual therapy. Sometimes they just need rehab because they're weak or they've got hypermobility and, they don't need decompression. They need strengthening, load strengthening. And if there is nerve root compression or facet joint dysfunction that's not responding to classic treatment or conservative care, then I might recommend spinal decompression. But the spinal decompression, every single patient that I do recommend it for needs to understand that there has to be rehabilitation. Because the spinal decompression only does one thing. It unloads the nerve, helps the nutrients get back into the disc and helps modulate pain. But it doesn't build your strength.
No.
So we get the pain under control. We get the sciatica under control. We reduce the tingling, the numbness and the burning and the cramping. But it doesn't build load tolerance. So the next part of their program needs to be a rehabilitation program. And the women that go through that process are amazing. They feel great. They're happy again. They've got their life back again.
That's the protocol.
That's the protocol that we use. Yeah. So we've been doing that for a long time now. We've sort of really refined
Amazing
it.
results as well.
Yeah. Yeah. So that's my type of common patient pattern. Today in our podcast, we covered a brand new 2026 study from Nature on spinal decompression positions, and also we covered real patient case studies from inside our clinic this week. Thank you for listening with us. We know your time is valuable, and the fact that you're still here means that this content mattered to you, and that means everything to us.
3 things before you go. First, if this episode taught you something, share it with one person who needs to hear it. That's how this podcast grows. Second, subscribe wherever you're listening and leave us a review. It genuinely helps us reach more people who are struggling with pain they've been told they just have to live with. And third, we want to hear from you. What controversy do you want us to tackle? What trend should we investigate? What research do you want us broken down? Message us on our socials or DM us. Your questions shape future podcasts. I'm Dr. Ali Yusuf, osteopath, joined by Dr. Houda, osteopath. This has been the Allied Health Podcast. Stay curious, stay active, and we'll see you next episode.
Thank you so much for listening, guys. You can follow us on our YouTube or our Spotify, where we're going to have our podcast. And if you have any questions or any topics, definitely pop them in the comments below. Thank you.